So we'll have to select on that and then proceed to the next step. Anywhere anyone is stuck, anybody has any doubt, please raise your hand. We have Dr. Shankit and Dr. Hemvati there. They will come near you and then sort things out. So in this step, we'll have to adjust the bone threshold of the patient. So it is suggested that we get rid of most of the, so you see the panel that's behind the head. Also make sure you don't lose any important structure. Somewhere around 550 will be more ideal. So when you had reached this page, the software itself has selected the best threshold. So we have a gradient of 276. So the software has selected that, but we still have the freedom to increase or decrease the threshold. So somewhere around 500 should be okay. So the idea is to get rid of as many artifacts as possible without losing the important structures. So this is a very important step where you'll have to adjust the skull model to a natural head position. So for this is the step where I suggested that we have the clinical photographs of the patient in natural head position, and then you can open both the windows side by side and then compare and do it. So as of now, because we don't have the clinical photographs, we just try to orient it in such a way that in the frontal view, the vertical line has to coincide with the skeletal midline. So you have two options, rotate and translate. When you click on to the rotate option and you are inside the patient head, you get to rotate it this way. And when the cursor is a bit far away from the patient's head, you get to rotate the model this way. And similarly in the other views. And when you click on to the translate, you can translate the entire head. So now we'll go step by step. First, we'll try to orient this vertical line to the facial midline. And now we also try to orient this horizontal line in the frontal view along the infraorbital. So now you can observe that the line on one side is inside the orbit, the other side is in the infraorbital plane, which means that I will have to rotate it this way so that my line lies in the infraorbital bilaterally. And then when you view the lateral aspect, the idea is to orient the horizontal line along the Frankfurt's horizontal. So anteriorly it should coincide with the infraorbital and posteriorly along the porion. And here the vertical line and the vertical line here can be positioned along the, yeah. I think there's some issue with this. It's okay, you can switch this on. No, I think it's completely fine with this. Until then, I can adjust with that. Can you switch this on? Yeah, okay. So in the lateral view, we have to orient the vertical line along the soft tissue nasion. Yeah, you will need to adjust it again little bit. So repeating it in the frontal view, we just have to make sure that the vertical line is along the facial midline and the horizontal line falls along the infraorbital. In the lateral view, the vertical line along the soft tissue nasion and the horizontal line along the infraorbital anteriorly and along the porion posteriorly. And in patients who doesn't have any major asymmetry issues, that will also align along with the vertebrae. So if you're done with the frontal and the lateral view and you're happy with that, we can proceed to the next step. There's one other option that you can use here is the transparency. So when you click on this option called transparency in the right lower aspect of the dialog box, you'll be able to adjust the soft tissue transparency. You can adjust that if you would want to view the shank. So you just have to, you can, in the axial view, you can orient it in such a way that the horizontal line touches bilaterally the zygoma in order to see any um, differences or discrepancies that can be done. But soft tissue nasion is fine. If you move it that way, you won't be able to orient the vertical line along the soft tissue nasion in the lateral view. So we can just limit it to adjusting in the frontal and the lateral view. It's more than enough. So you can adjust the transparency to see the soft tissue and the hard tissue. And when you're fine, you can click onto the option called finish. So there are few other options here. This single arrow mark is for doing any action, particular action or moving a point or any such thing. You also have an option of zoom in and zoom out. You can scroll to zoom in and zoom out. So once you're done, you'll be redirected to this page where the mandibular nerves will be automatically detected. It will take a couple of minutes. I hope all of you are done with the natural head position orientation. Anybody, any doubt anywhere? And then you can go back to the home page, click onto the option called home in the top left corner. So I request everybody to save the file after each and every step, because if the laptop doesn't cope up with that, sometimes it might crash in between. So you can reopen the file if you save it. So kindly save after every step. So you can use the option save as or save, and then select a folder and save it inside that so that we can proceed with the next step. So now we are done with uploading the DICOM files of the patient. The next step is to create the surgical models. So the upper and maxillary and the mandibular scan, we have it saved as STL file. So you can select the option of from STL from the drop down box and then browse the upper and lower scan. So in the files that we have given, kindly open the intraoral scan folder and then you'll have one file named as maxillary and the other file named as mandibular. So you can select the option maxillary in the upper and in the lower scan, kindly select the option mandibular. Just single click and open the file. Once this is done, you can import these files. So you'll be able to see the dental scan set. So you have this option to rotate the models and then view them from all the aspects just to make sure all the expected tooth structure and everything is completely visible. And many a times it so happens that we upload the different scans to different things, for example, lower into upper, upper into lower. So you also have this shortcut option of switch cast where you can switch the cast. So when you're happy with that, you can click on to next. Now we will have to select a few landmarks to slice the maxillary and the mandibular occlusal plane and also to identify the condyle. So on the left side, you have this dialog box which says or what landmark has been actually marked. So first is the right mandibular condyle. So you can keep a point. Just make sure you mark it in such a way that it lies on solid bone. For example, here, while adjusting the threshold, a bit of bone is lost. So when I happen to mark it right on the condyle, it might end up somewhere in the base of the skull. Many times this happens. So mark it in a point where there is solid bone. We can still adjust the positioning later. So if you're not happy with the point that's marked, you also have this option called re-indicate landmark, where you can adjust the landmark. And if you happen to have any bony area that's like missing because of adjustment of the threshold, you also have the option to adjust the threshold right now. So first is the condyle, next is the first maxillary molar. If you don't have the first maxillary molar in any particular patient, you can also mark the point a bit posterior on the second molar. Doesn't matter because this is to establish the occlusal plane. So once you're done with marking all the points, then you'll establish a occlusal plane and two boxes along each of the condyle. You also have the freedom to move the boxes to make sure that the condyle lies inside it. View it from all the sides, make sure that the condyle lies inside the box. Now all the 3 points that we have kept on the maxillary molar and the incisors are adjustable. So you can select onto the single cursor and adjust these points in such a way that the occlusal plane is accurate as much as possible. Once you're done with that, you can move on to the next. So after this, either the models are accurately overlapped and oriented, or it might fail to align the upper or the lower jaw or both the jaws sometimes. So you can adjust the alignment. So what we need to do is that we need to keep three or more points on the DICOM file as well as on the STL model of the cast so that it can orient it better. So we suggest to keep it either on the occlusal plane or the incisal tips to be more accurate. It's not necessary that you'll have to only follow what the instruction box says. For example, it says mark a point on the lower right first molar. So it's not necessary that you mark it only on the lower right first molar. You can choose any other point which you can visualize properly and mark the corresponding point on the STL file of the model as well. For example, here I'm not able to visualize the occlusal aspect of the second molar, so I wouldn't choose that. I'm able to visualize the cusp tip here, so I would prefer to mark a point there and mark the corresponding point on the cast as well. So it's preferred that you mark minimum 3 points or more for accurate overlapping. If at any point you've marked it in a wrong place and you want to redo it, you have this option called re-indicate all the points. So you can do that or remove a selected point and then insert another point. So if you're done with three or more points, then you can finish the option done. And then it'll start recalculating. Are we all on the same page? No? Does anybody need help? Okay. So now it has separated the cranium from the mandible and has overlapped the STL files that we uploaded of the occlusion. So we just need to scroll through and check if the overlap is satisfactory. So as you can see, the background is of the DICOM and the white outline is of the model. So if along the occlusal plane you find the uh, superimposition to be good, then it's fine. If you find it to be not good, you can still go back and adjust the alignment of each of the arch individually. So you have an option called adjust upper alignment and adjust lower alignment. So you can do that separately by marking multiple points like we did in the before step. You can also visualize it here. If you're satisfied with that, then we can proceed to the next step. We're done with the step 2. Now I request you to save it again before we move on to the next step. So from the home page, you just have to go to, no, please don't load the occlusion right now. So we'll try to do it in two ways. First is when you have the existing model in hand and then you put it into the final occlusion and scan it, you have the scan in hand. We do have it in hand, but still I would want to navigate you through what if you don't have it. So go to the option called to surgery plan. You have multiple options in the top dialog box. It says diagnosis, surgery, splint, and advanced. So go into the option called surgery and then click on the option called virtual occlusion. So in this, sorry, sorry, how to go there? Okay, fine. So you were in this page, right? So please select the option called to surgery plan in the top left corner. And then you'll have multiple options of diagnose, surgery, splint, and advanced on top. So you can select the option called surgery, and then in that you'll have an option called virtual occlusion. The entire idea of this is to select particular points on the maxillary and the mandibular cast such that springs are established between the points and then it fits into occlusion. So wherever you're putting your point, a spring will be attached from that point to the corresponding point in the mandibular arch and it will act to put the arches in the occlusion. So it's not very necessary that you mark the exact points that's been mentioned here because this is for an ideal arch with proper arch form, all the teeth present, whereas the case file that you have is of a cleft patient and then not all the teeth are present. So we'll be marking the points and then click on to option next. When you're not satisfied when you marked it somewhere else, just you can use the option re-indicate the point and then when you're done, you can move on to the next. So now I would place the points in the mandible in such a way where I would want my maxillary first molar. So I had my point placed on the maxillary first molar. So if I place the point again on the lower molar, so I would just have it placed exactly there. Whereas this is like a class 3 case. I would want my maxilla to come more forward. So I would place my lower points also a bit forward so that my maxilla is pulled forward. So when I mark the occlusal point, I don't want to mark it on the first molar. I would mark it on the second premolar rather. So if you can observe, springs were established between the upper and the lower arch. And then we have this occlusion right now. So what you see in this occlusogram is the point of contact. So wherever you see a blue or green area of contact, it's ideal. Wherever you see it more towards the red, it means there is a premature contact there. So when you're satisfied when the contact is distributed in an even way, then it's fine. Did we all get it? Are we done? Anybody needs any help? Everybody has got, yeah, exactly. Wherever you would expect a contact, tooth contact, not there, then we have to adjust the springs again. So you can remove all the springs and then redo it. So, so click on the option remove all springs and then click visibility. Then you have the option of switching on and off the visibility of the mandible and the maxilla separately. And then I say add spring. And then I would start adding wherever I would want my springs to be attached. So I see the maxilla, I attach the upper end of the spring, and then I would see my mandible and put the corresponding lower end of the spring. And then I would add more springs in the same way. Entirely from beginning. Okay, once the simulation is done, it's fine. You've gotten class 1, leave it there. If not, remove all the springs. You'll have to remove all the springs. You have an option called remove all springs on the left side. Select that. Hmm? Hmm. And then on the right side, you have visibility of the maxilla and mandible separately. So when you have it like this, it's quite difficult to visualize the occlusal plane and then mark where you want the spring to be attached. So just switch off the visibility of the mandible when you attach the spring to the maxilla, and then you will have the spring. If you can see, there is a spring that is established. So you have the upper point marked there. Now you switch off the visibility of maxilla, switch on the visibility of mandible, view the occlusal plane, and mark the lower point where your spring is supposed to be attached. So you manually attach springs like this one by one. And then when you're done with everything, you can click on the option simulate. So for example, now I just put one spring, and then when I simulate, so can you see just that one spring acting? So it just, that's what has. So the idea is to attach at least 3 springs, one in the posteriors on each side and one in the anterior. So when you attach, if you have a class 3 state, we would want the maxilla to move more forward. So you attach the spring more posteriorly in the maxilla and a bit more anteriorly in the mandible so that the maxilla is pulled that way. And the reverse way when it is a class 3. So you put your springs more anteriorly in the maxilla and posteriorly in the mandible so that it's pulled behind this way. In the anteriors, you would want the points to be marked on the palatal aspect of the maxillary incisors, and in the mandible, you would want it to be marked on the buccal aspect so that there is a positive overjet there. If you're not happy with doing the springs individually, you can just click on to back, 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 back so that you'll end up in this beginning state. Sorry? Yes. One on each molar and then bilaterally, of course. So if you want to do it the easier way, just click on to back, 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 and you'll end up in the first step, and then you start re-indicating the points. Border in the sense? Okay, I'm not able to understand what you're saying. Shank, can you see? So I've reattached the springs from the beginning. I put my mandibular points much more anterior, and now you can appreciate the increased overjet that I have achieved. So it's just playing around with the springs to achieve the required. So last time I had a better occlusion, occlusal contact. As you can see in the occlusogram, we just had a dispersed distribution of the occlusal contact points, whereas now we just have contact points along the premolars. So this is not so good. So the occlusion that we had previously was quite better because we had it dispersely spread along the occlusal plane of all the teeth. So I reposition the mandibular points a bit more posterior. Now you can appreciate I have good contact along the premolars and the first molar, a bit of open contact in the posterior along the second molar, but that's still fine. And probably around 3 mm of positive overjet and overbite. So when you're satisfactory, when the occlusion is fine, you can click onto the option finish. So this is how you do it when you don't have the existing final occlusal scan. If you have it in the home option, you can go and select onto this option called load occlusion. So again, we have the final occlusal scan in an STL format. So click onto the option called import STL file. And inside the folder intraoral scan, you have a file called final occlusion. Select and import the file. So now this final occlusal STL file will be used for further planning. So in this step, what we are supposed to do is the remove the base area of the upper and the lower cast. You can remove the excess. This is a scan of the occlusal cast, I mean the cast of the patient. So you'll have some extras. So you can remove them. You can adjust the breast size as well. So now what the software is trying to do is you uploaded the maxillary and the mandibular scan separately. And then you also uploaded the occlusal scan. It's just trying to overlap the two and then check if it's proper. So usually when you see all the outline in blue on the right side in the cross section, then it's usually you're not supposed to have any issues with that. So when it's satisfactory, you can view the upper separately and the lower separately if you select and unselect the options in the visibility. And when you're fine, you can click on to finish. So the last step of it is to create the skin model. Like I said, if you have the 3D photographs of the patient, it will be very nice to overlap the soft tissue and the 3D photographs. When the soft tissue simulation is happening, it will be much more better to visualize and then especially to convince patients. So you can adjust the threshold again and click on to next. It's just taking some time. I hope everybody is on the same page. If you need any help, please ask. We can utilize this time. Please raise your hands. Okay, okay, okay. Hemvati sir, mm, Shank, there. Okay, so when this step is done, you'll end up in another page. So where you'll have an option as to upload 3D photographs of the patient on the right, on the left, and then you can upload the 3D photographs if you have. Crash I- Ayushi. No, it's Ayushi's laptop. No, that is ours. Is ours sorted? Not sorted. அவ்வளவுதான் இது crash ஆயிடும். Crash ஆயிடும் தானே? Hmm? No problem. So once you're done with the skin model, you can select this option called to surgery plan. And then when you're done with the skin model, please save it again. Sometimes it might crash. And then you can go to the option called to surgery plan again. Now what we'll try doing is the osteotomy. So you will have to select a few points on the skull model, preferably as minimal as possible. So I would like to keep it to minimal as 4 points, one on each of the buttresses and one on each of the piriform rim. So you'll be asked to mark certain points along where you want your osteotomy line to be. So move around, view it from the lateral aspect, mark a point on the buttress, the piriform rim, and similarly on the opposite side as well. So once you're done with marking the points, you can click on to next, and then a plane like this will be established. So our aim is to separate the maxilla from the skull. So this plane has to completely separate the maxilla from the skull base. So you just can now adjust these points that were placed before to a desired location. Viewed from the worm's view, most of the times the zygoma might not be separated from the maxilla here. For example, if it is somewhere here like this, so you can see that the plane is not completely transecting the zygomaticomaxillary buttress. So I will have to reposition this particular point in such a way that the plane is established completely separating the maxilla from the skull base. So for people who would want to visualize the roots of the teeth and then decide upon where you want your osteotomy cut to be, so you have an option on the right side where you can switch on the visibility of the scanned patient and then select this option called bone diffuse. Now in the surgery model, switch off the visibility of the cranium. Now you'll be able to see all the tooth roots and you can reposition your points accordingly. I will repeat it in the visibility. Initially, you will have the cranium visualized like this. You'll have to switch off the visibility of cranium, switch on the visibility of scanned patient and select the option bone diffuse. Now you can zoom in, move around, see exactly where the roots are, how supro-inferiorly your points are placed. If you're not happy, you can move them. And when you're done, you can again switch off the visibility of the bone diffuse and switch on the visibility of cranium. Now, before we select next, visualize it from all the aspects. Now I find that the plane is not completely transecting through the zygomaticomaxillary buttress, so I would want to adjust my point in such a way that it cuts through. When I'm happy with that, we go ahead and click on to next. So what it does, it splits the maxilla from the cranium. So if it's done right, the maxilla will appear in a different color. So when you're done with that, you can click on to finish. Next is to do the sagittal split. So it will ask you to select the side you would want to work on first. And then you'll be asked to mark a few points. First, from the medial aspect, you'll be asked to mark 2 points that the cut where on the medial aspect of the ramus, and you would want it to be above the lingula. So just mark 2 points above the lingula where you want your horizontal cut to be. And then next you'll be asked to mark the vertical cut related points. So you'll mark it along the supro-inferior extent of where your cut should be. When you're done with that, you click on to next. You'll have a plane established like this. So what we would want to check is that the proximal fragment is separated from the distal fragment. So whatever appears lateral to the plane will be included in your proximal fragment. The area of the mandible that's medial to the plane will be included in your distal fragment. Move around and then adjust these points in such a way. For example, many of you might have this problem of, for example, like this. Somewhere the plane is like cutting through the ramus. So you'll have to visualize it from the posterior aspect. Move these points a bit medially so that it cuts through the ramus. Visualize it again from the worm's view and reposition these points so that it splits the mandible sagittally. Visualize it from the medial aspect to determine the anteroposterior cut on the medial aspect. This way, view it again from the lateral aspect and make sure entire ramus is included in the proximal fragment. When you're done with that, you can click on to next, and you can try doing this on the other side as well. This might take some time. If you're stuck anywhere, please let us know. Please raise your hands. Can we move on to the next step? Is everybody done, or do we wait for some more time? Okay. Hmm? So, will you just check if everybody is done? I think everybody is not okay and they're not asking for help also, especially that group. No, no, no. We're just done with the slicing and other things. We'll have to do the planning, and then the splint. Yeah, we can do it if they're all done, but all of them have done it like there's some gutbird with everything, I guess. So they're just addressing one by one. Okay, so we'll move on. Okay, so when you're done with that, we go ahead with the planning. So, like I said before, it's either maxilla based or a mandible based. It's going to be a maxilla based or a mandible based surgery. Maxilla based in the sense you'll be able to move the maxilla, not done, but they're not asking for help as well. Okay. Okay, I'll just tell we won't do any movements though. So, maxilla based in the sense you'll be able to move the maxilla and the mandible will follow. In case of mandible based surgery, you'll be able to do movements in the mandible and the maxilla will follow in the occlusion. And you also have an option of free hand where you can manually move it independent of the occlusion. So once we are done with the slicing and the osteotomy, then we'll move on to this step. I'll quickly come there to help you guys.
Hello. Hello. किसकी? किसको? अजय। ओके।
So the reference that we are going to take, you can click on to this option called 3D viewer, show reference line. And then you can move in such a way that the vertical line falls along the nasion. So this is called Barcelona line. What we usually follow is that the maxillary incisors should be at the level of the line or even up to 0 to 4 mm ahead of the line. So you can go to surgery, and there are multiple options to move the maxilla. You can either translate or rotate. So in translation, you have right and left movement. If you view from front, like you can see, you can move like when you move the maxilla, the mandible also moves along. You can move it either there, or you can enter the values as to how much amount of movement it has to be. So when it is a positive value, the maxilla moves towards left. When it's a negative value, it moves towards the right. And then you can move it back and forth. So for example, if I just put it as 3 mm, it moves 3 mm forward. So I've moved it 8 mm forward, and I and I can appreciate that the incisors are touching the Barcelona line, so I'm happy with that. You can also translate the entire maxilla up or down. It is a bodily movement that you're doing here. So you can impact the entire maxilla, or when it is a negative movement, it just moves down. So we are not going to do any such movements here. And then once you're done with the translation, once you're done with any kind of movements, you just have to finish it to access the other movements. And then next we go to rotation. So in rotation, you have an option to change the pitch, roll, and yaw. So the point arises as to around which point does it pitch, roll, or yaw. So you have this option where you can change the point of rotation, which says adjust point of rotation. So as of now, the point of rotation is at the incisal tips. So I keep it here. So when I do any kind of roll, you can observe that it rotates around the point of rotation which is there in the incisal tip. So when I do it likewise, one side of the maxilla gets impacted, the other side goes down. If at all I have a good occlusion on the right side, I want to maintain it that way, or correcting the cant like we saw in the clinical patient, and we want to just impact one side. At that point of time, I would go and change my point of rotation and keep it on the molar on which side I don't want any movement. So I would keep it here. You can see when I do that and then do the roll, you can observe that around my point of rotation, the movement is very minimal. So one side of the maxilla stays in the same position and the other side just gets impacted or moves downwards. So in cases where you'll have to do a cant correction, you can play along with this. And then the pitch. So when I turn it positively, there's a clockwise rotation, and the other way around, the anti-clockwise rotation. So again, if I adjust my point of rotation to the incisal tip, I'll just have posterior maxilla going up or down with pitch. You can observe here, the incisal edges almost stay in the same position. When you change your point of rotation a little backward, you'll have both the anterior maxilla moving downwards and the posterior maxilla moving upwards when you do a clockwise rotation. And then similarly yaw, whenever you'll have to rotate out one side of the maxilla. Okay, at this point, if you're okay with the movements that you have done and it's satisfactory, you can remove the reference line. So let's assume you want to see how much of, if at all we had done any pitch, roll, or yaw, and you want to measure the distance between the bony fragments at the level of buttress or the pyriform. Then you select this option called diagnose, and then you have a scale like option that says distance. So you can actually mark 2 points, one on the cranium along the osteotomy and one along the osteotomized fragment to measure the distance between them. This is one way to do it. The other way is to use this option called point. Whenever you keep that point at a certain place, it shows you from the previous original position how much of movement has occurred. So you can see here there's like minus 0.8 mm of downward movement here and anteriorly again. So one more important thing, you would also want to visualize the gap between the proximal and the distal fragments. For example, we have done just 8 mm of advancement of maxilla, so we know there is 8 mm of advancement of maxilla. Whereas your mandible has just followed the maxilla in occlusion. So if you actually want to know how much amount of advancement of mandible has occurred, you can again measure it and see the amount of gap. However, you can observe on the other side, there's a bit of overlap here, which means that there's a rotation that has happened in the mandible. A yaw kind of movement has happened in the mandible to fit into occlusion. Any point of time you don't want to visualize any particular measurement or landmarks, you can go into this option diagnose and then you can switch on or off the visibility. So that's about the movements. You can also try this mandible based option and you can see how you can bring about movements. There is also an option called freehand where you'll be able to move the maxilla and mandible independently. So when you're done with the movements and you're fine with it, then we go to this option called splint. Can we proceed? Yes. So depending on what you choose. So if I choose maxilla based surgery, then you will just have to move the maxilla. The mandible will follow in the final occlusion. That's what we meant when we said it's a occlusion based planning. So we have already uploaded the final occlusion. So the mandible just follows the maxilla in the final occlusion. So the entire complex moves likewise. Yeah, for bijaw. Yes. Yes. Yes, yes. Mm-hmm. Mm-hmm. Okay, so it won't be an issue for you to create the splint first only with maxilla and only with mandible. That's how the splints work. They are automized that. No, the splint that we'll make will be stepwise. The intermediate first with only maxilla moved and the final with both in the final position. We'll get both. Yeah, because it is automized that way that it will create an intermediate splint with only the maxilla moved. Here, the idea of us doing together is to visualize the final outcome. If you'll have to move the maxilla separately and then you'll have to move the mandible into the proper occlusion, I think it might be very complicated. So, if you just move the maxilla and see the profile, if you're satisfied with that, you can go ahead. Automatically, it creates the intermediate splint with only maxilla first and then the final occlusion as the final splint. So, why would you want to know that? So whatever maxillary movement you're doing here is what you will be doing in the even in the maxilla first. So for example, I have translated my maxilla 8 mm forward. So in step 1, where you'll be using your intermediate splint, your maxilla will come 8 mm forward, and that's it, isn't it? When you're done, you can click on to this option surgical splint. So it will just ask you to save the changes whatever you've done in the surgery. So for people who, you might have another doubt as to, you have planned it along with maxilla mandible, you like the profile 8 mm of maxilla and whatever the occlusion based mandibular movement. Now on table you decide that you want to do the mandible first for some reason. You did the planning, and then but you want to operate on mandible first. You can still change here while doing the splint whether you're going to operate on mandible first or maxilla first. Even though the planning can be either of the two, you can do a planning with maxilla based surgery, and then still you can operate on mandible first and create the intermediate splint likewise. So you have that flexibility. So here you have some intersection of the models, which means that the upper and the lower teeth are coming in contact and we can't create proper splint. So we open the mandible until that intersection is gone. So I increase the degree of auto rotation of mandible, and then at certain point the alarm doesn't show up, so which means that it's free of contact, and then I click on to next. So here what we see is, this is how much of occlusal surface the splint will be covering. So it's very mandatory that we include all the cusp tips and the incisal edges. And it's also preferable to not extend it until the posterior margin of the last teeth, because there might be some kind of soft tissue interference. So it's preferable to limit it to at least the mesial aspect of the last tooth. That's how we do it. And then anteriorly, definitely covering all the incisal edges. When we are done, we can click on next. So now we can adjust the thickness of the splint, which means that if you would want to add more material to the buccal and the lingual aspect of the splint. So in between the occlusal plane, it's going to be the same. There's not much of material going to be added there. When you increase the thickness, you tend to add more material on the buccal and the palatal aspect of the splint. And if at all you want to use any buccal extension, for example, few surgeons would want to pass the IMF wire through the splint when they are doing the IMF on table. So in such cases, you can use this option of add buccal extension and add wire holes wherever you would want your wire holes to be for passing it through the splint and doing the IMF. So you can position the wire holes likewise. And then next you can add your label. We would want to mark whether it's an intermediate or a final splint and the patient's name if you're doing multiple to avoid confusion. So it just comes on here. And likewise, the extension of the extension that you chose before will be applied for the final splint as well. Here you have an option of adjusting the thickness, including the buckle extension and the wire holes. When you're done, you can click on to next. Okay, so now your splints will be prepared and then the STL file will be saved. So whenever you want to print it out at your place, you have to choose this option in the home page called export for local production. And then you can save it with the name that you want to. So these will be saved as STL files. You can use them for local printing. And then if you want to view the entire report of how much amount of movement you did, the measurements you made, you can click on to this option called create report. If you want a basic one, a basic, or the extensive one, like you wish, and you can export the report as well. Now we are done with all the steps. Probably we'll take another half an hour for all of you to finish with all these steps. And when we are done, if we still have time, we can try out another case as well. We'll give you the data and we would want you to try it out. And if at all you have any issue, we come there and then help you out. So this is the final report that you have. You'll have a clear picture of pre, intermediate, and post. You can also view the occlusion from all the aspects, the movements and gaps between the osteotomist maxilla and the cranium. Similarly with the mandible and the soft tissue simulation. And then you will have a tabular column where all the movements are summarized. Like for example, we just did 8 mm of forward movement of maxilla, so it's just indicated in translation. And in mandible, you can see that it was defined by the virtual occlusion scan. So if at all we take any screenshots, it'll be indicated here. For the orthodontists who also want to do the CEF analysis, you have an option in the diagnose called surgical CEF. So if you click on to that, it'll ask you to mark all the points. And then when you're done with marking all the points, all the planes and angles will be established and you can visualize them in the screen and then decide upon how much amount of movement you would want to do. So in this option called diagnose, in diagnose, yeah, you have surgical CEF. So if at all you want to customize the landmarks, points, and other things, In the home page, you can go to General Preferences, and then in that you can select the option Surgery Ceph, and then you have entire Ceph dictionary. So you can select or unselect. So whatever you have selected, it'll ask you to mark only those points and planes. So you can limit it to particular analysis that you want. So they also have a basic IPS cephalometric analysis and advanced IPS cephalometric analysis. Whatever works best for you, you can select onto that so that you have only those points marked. So people who have completed with this particular planning, could you please raise your hand so that we can provide you with the next patient data? Okay.